Are you junior anesthesiologist or intensivist about to start new ICU rotation? Get comfortable because I'm about to share the most crucial advice. I wish I had known all of them when I started my ICU rotation. These insights became invaluable to me on my ICU journey and will definitely make your clinical life much more easier. Hello there and thank you for joining us on Anesthesia and ICU News. I'm Martin and in this video we will delve into some practicalities for junior intensivists before their first ICU shifts. So let's jump into it. Imagine everyday situation. It's midnight, you've already been on your feet for over 20 hours and somebody calls you to review a patient on the ward or in the emergency department. The first and the most trivial advice would be to keep in mind the ABC approach in any newly faced situation. Now you are probably thinking, why am I even listening to this? I know ABC from my med school. Well, hold up buddy. It's very easy to get lost in the presentation of complex medical history. You wouldn't believe how many doctors can easily become distracted and confused by unimportant details during presentation, causing them to lose focus on the life-threatening problems that we as intensivists should address within the first few minutes. Starting with evaluation of the airways. If the patient is talking to you, then you can be quite sure that he has patent airways. Ask yourself, is this patient comatose? Is the patient even breathing? And of course, try to answer these simple questions. Auscultate the breathing sounds. Are they bilateral? What is the saturation? Do we have ABGs? For circulation, check the pulse on the periphery and centrally. Are they referent or is the periphery cold? Can you see the mottling? Check the capillary refill time to have some idea about the microcirculation. Feel free to ask the nurse to help you with monitoring like saturation, non-invasive blood pressure, ECG, exactly the same things that we are using in the theater. At first sight, these points can seem so elemental. When you are tired during night, alone, and you need to face a situation that seems overwhelming, trying to simplify it by using ABC approach can really help and you can think much more systematically and clearly. My next small advice would be about not looking at a single snapshot number, but trying to look for the trends. This has application for all situations, not only for patients in the ICU, but for ICU referrals as well. It is generally easier to spot some abnormal numbers like CRP 200 or low hemoglobin, but looking for trends in ABGs of COPD exacerbation patient or non-invasive ventilation, for example, that is not improving, despite our full management can signalize that this patient will require close monitoring and likely even intubation and mechanical ventilation at some point. It can be even more tricky to spot, for example, changes of creatinine from 50 to 100 and just slight decrease in urine production. But even these changes can sometimes have massive impact and should be addressed, as this can be the first warning of acute kidney injury and we should be trying our best to find the cause. If patient is referred to you and you are considering for ICU admission, stay organized. What I mean by this? Say to yourself, or better write it down just for yourself, what organ systems are injured. You can use alphabet for your assistance or any other mnemonic help to go through all major organ systems. Take for example SOFA score, looks similar and can be handy. Let's look at this example case and have a look what organ systems are injured. We can see in these oversimplified notes much more clearly what organ systems require what type of organ support. This is of course oversimplification and you can always lose some kind of information when you are trying to make these kinds of notes for yourself. Nevertheless, it can help you make very clear what level of care this patient needs and what kind of organ support this patient requires. If you combine this with previously mentioned trends, it can look like this, and you can have a very nice picture of the patient situation. You can do it just in your head or on the paper, whatever suits you. Just always stay organized. Okay, so you made the decision about intubation. If you plan to intubate somebody, try to think where it would be the best place for it. The most likely answer would be the operational room or ICU, where you have your team that's familiar with the procedure and you are familiar with the environment as well. On the other hand, intubating somebody on the ward can be extremely difficult because of a lot of reasons. Local nurses are not always familiar with it, you don't have the right equipment for it, so you need to bring it yourself. And if any complication occurs, it would be much more harder to manage it. Plus, if you successfully intubate somebody in the ward, don't forget that there are usually no ventilators available, which you need to bring, and even infusion pumps or monitors can be sometimes harder to find. Please, I'm not saying intubation on the ward is absolute contraindication. No, but it can go very easily wrong. Try to always ask yourself if you can transport the patient first and proceed with intubation in a safe, familiar environment. Another question you should ask is, do you have solid peripheral access the same way you have one in theater before induction of general anesthesia? If the patient has only one blue G22, that sounds like we would benefit from another bigger one, don't we? And what about arterial access and continuous blood pressure monitoring? Imagine patient with pneumonia, respiratory failure that you want to intubate. This patient has infection and possible sepsis, and even if it does not look like this patient can possibly hemodynamically deteriorate after induction and intubation, having an art line ready in advance can be very handy. Considering that art line will usually take you around 5 minutes, asking yourself if you have that 5 minutes to get properly ready for everything that can follows. Rule of thumb can be if you have time to transfer patient to the ICU, you have the extra 5 minutes for the art line as well. As we are coming to the end, I would like to thank you all for watching. Hit the like button, leave a comment down below if you enjoyed this video, and most importantly, don't forget to subscribe. And as always, steady hands for cannulation.